Welcome to the Radonc Smart Review GU Cancer series.
Glad to be here diving into this.
Yeah, so imagine you're looking at a pathology report, right? And it definitively says pure seminoma.
Right.
You've got the tissue diagnosis right there in your hands. The surgeon has done their job perfectly. You confidently present a treatment plan for a seminoma, and in doing so, you just outright fail your oral boards on the spot.
Ouch. Yeah.
And, well, far worse than that. In the real clinic, you fail the patient. You could potentially cost them their life.
That is the ultimate nightmare scenario.
Exactly.
But it happens. It really does, because stage 2 is where the training wheels completely come off.
Yeah, you're not just like regurgitating the natural history of a localized tumor anymore.
No, not at all. You are actively synthesizing conflicting clinical data in real time. You have to classify the patient using these incredibly strict imaging criteria. You're navigating this really nuanced fork in the road between systemic and local therapies, right?
Right, and you have to defend the underlying radiobiology of your choice.
Exactly. And ultimately, if you go with radiation, you have to design a field that requires absolute, millimeter-level anatomical precision. If you can't explain the why behind the what, the examiners, and honestly, the disease itself will completely expose you.
So true. So we really need to ground all of this in a tangible reality today. Let's build a patient and keep him in the room with us for this entire discussion.
I like that. Let's do it.
Okay, so our case anchor is a 38-year-old man. He is 6 weeks post-left radical inguinal orchiectomy for a 4-centimeter mass.
Okay, 38, left side, 4 centimeters.
Yep. Final pathology demonstrates pure classic seminoma. There is no spermatic cord involvement, no lymphovascular space invasion.
Good.
Preoperative beta HCG was mildly elevated, sitting at 35, while his pre-op AFP and LDH were completely normal.
Okay, pretty standard so far.
Right, and now, post-orchiectomy, his markers have strictly normalized. Oh, and he banked sperm prior to surgery.
Nice. The normalized markers and the sperm banking, those are critical details. I mean, they basically shape the entire landscape of his survivorship and our immediate decision tree.
Exactly. So here's where it gets interesting. His staging CT of the abdomen and pelvis shows a single 1.8 centimeter left periaortic lymph node.
Just the one.
Just the one. It's located just below the left renal hilum. Chest imaging is totally negative. No prior inguinal or scrotal surgery.
Okay.
He's sitting in your office looking for a recommendation. And if this is a board exam, the examiner is looking for 3 things from you. What is the stage? What are the options? And if you choose radiation, you need to walk me through the field design.
Right, the classic triple threat.
Yeah. So to tackle that first part, the staging, we have to look really closely at the anatomy. A lot of residents get tripped up because a testicular tumor's primary landing zone is way up by the kidney, right? It's not in the pelvis.
It is not in the pelvis, and that goes straight back to embryology. You have to remember that the gonadal ridge originates high in the retroperitoneum, right next to the developing kidneys.
Right.
And as the fetus develops, the testicles descend into the scrotum, but, and this is the key, they drag their vascular supply and all their lymphatic plumbing all the way down with them.
Yeah, the embryological tethering is it dictates the entire staging system. The testicles maintain those high abdominal connections.
Exactly. So the venous drainage of the left testicle empties directly into the left renal vein,
Right.
while the right testicular vein empties directly into the inferior vena cava and the lymphatic channels. They follow those exact same venous pathways.
So for our patient with the left-sided primary, the primary nodal basin is the left periaortic region.
Yes, specifically concentrated right near that left renal hilum.
And if he had a right-sided primary?
Then we'd be looking primarily at the paracaval and interaorticaval nodes, basically extending from the right renal hilum straight down to the aortic bifurcation.
I always like to visualize this as an express highway.
Oh, that's a good way to put it.
Yeah, like the lymphatic fluid leaves the scrotum and just gets on a closed turnpike that entirely bypasses all the local pelvic roads.
Right. It doesn't stop in the groin.
Exactly. It shoots straight up to the retroperitoneum. The only scenario where that lymphatic fluid takes a local exit into the pelvic or inguinal nodes is if there has been severe road work.
Road work. I love that.
Right. And by road work, we mean a surgical disruption of the natural anatomy, like a prior inguinal hernia repair or an orchiopexy for an undescended testicle.
Or the classic oncologic sin.
The transcrotal biopsy.
Yes. Where a well-meaning but totally misguided surgeon violates the scrotal skin.
It's just a disaster when that happens.
It really is. Because if that transscrotal violation occurs, that neat, predictable retroperitoneal drainage pattern we just talked about, it is instantly contaminated.
Right, the tumor cells can now just access the superficial and deep inguinal lymphatics or the pelvic lymphatics.
Yeah, which drastically expands the volume of tissue at risk. It's a mess.
But in our pure, unviolated case anchor here, the road is intact. The disease is isolated to that 1.8 centimeter left para-aortic node.
Okay, so let's size that up for staging. The cutoffs here are really rigid. You have to know them cold.
Yep.
Stage IIA is defined by a node 2 centimeters or less in greatest dimension. Stage IIB covers nodes greater than 2 centimeters up to 5 centimeters.
Then it's go.
Stage ISC is strictly reserved for bulky disease, so anything greater than 5 centimeters.
Okay, so looking at our guy, he has a 1.8 centimeter node. He fits perfectly into the stage IIA definition.
Technically, yes.
So let's say an aggressive resident looks at this 38-year-old, notes the stage IIA classification, sees the 1.8 centimeter node on the CT, and says, let's get him to the simulator tomorrow.
Oh, no.
Right. But if I'm sitting across from you in the clinic, why shouldn't I just, pull the trigger and start his radiation mapping right now?
Because rushing to simulation right there is a massive trap. Well, think about it. We have a 1.8 centimeter node. It's technically enlarged by standard radiologic criteria, sure, but it sits in this incredibly dangerous gray zone. We really must consider the physiological context here.
Because of the surgery.
Exactly. This patient just underwent a radical inguinal orchiectomy 6 weeks ago. His body is in a state of intense wound healing and systemic inflammation.
Right. If we think about the retroperitoneal anatomy, the lymphatic channels that drain that surgical bed are basically working in overdrive.
Yeah, they are clearing cellular debris, inflammatory cytokines, localized hematoma byproducts. All of that is traveling from the inguinal canal up into the retroperitoneal space.
So that localized immune response is frequently just causing reactive lymphadenopathy.
Exactly. That 1.8 centimeter node might be packed with metastatic seminoma cells, yes, but it also might just be packed with completely benign macrophages and lymphocytes that are just responding to surgical trauma.
So how do we know?
The key discriminator here is his blood work. His post-orchiectomy markers are strictly normal.
Right. We said AFP, beta-HCG, all normal.
Right. If his markers were markedly elevated, the probability that the node harbors active cancer skyrockets. But with normal markers, we simply do not have definitive proof of metastatic disease.
And if you just go ahead and irradiate that node today, you might be treating a benign reactive process.
Yes. You'd be committing a 38-year-old man to a lifetime of secondary malignancy risk for absolutely zero oncologic benefit. It's malpractice.
Wow. Okay. So the modern board defensible answer for the equivocal sub-2 centimeter node with normal markers is the waiting game.
The waiting game. We hold off on any therapeutic intervention, and we mandate a repeat cross-sectional imaging study of the abdomen and pelvis in 6 to 8 weeks.
We just need that surgical inflammation to subside.
Exactly, because if the node is benign, it will stabilize or it will even regress on that follow-up scan.
I mean, it must require immense clinical discipline to look an anxious cancer patient in the eye and tell them that the best action is inaction for 2 whole months.
It does. It's one of the hardest conversations. But you must frame it as protecting them from unnecessary toxicity. You're keeping them safe.
Okay, so let's assume we maintain that discipline. We wait the 8 weeks, the patient returns, we repeat the CT, and, the node is no longer 1.8 centimeters.
It grew.
It grew to 2.4 centimeters.
Okay. So now we have unequivocal, radiographically progressive metastatic disease. He has officially crossed the threshold.
We are dealing with confirmed marker-negative stage IIA, bordering on early IIB seminoma, right?
Yes, and at this point, intervention is absolutely mandatory.
Now, historically, the clinical pathway here was rigidly dogmatic. For decades, residents were basically hammered with the axiom that stage IIA, pure seminoma, mandates radiation therapy, full stop.
Oh yeah, that was the textbook answer forever.
Right, but the oncology community has moved far away from that kind of monolithic thinking. We really have to offer a much more sophisticated set of options now.
We do. If you walk into an oral board scenario today and state that radiation is the only acceptable treatment for stage IIA seminoma, you just flag yourself as completely out of touch with contemporary guidelines.
So what are the actual options?
For marker-negative stage IIA, and specifically for low-volume stage IIB disease, radiation therapy and multi-agent cisplatin-based chemotherapy are both considered standard Category 1 first-line options.
Both of them.
Both. And actually, at highly specialized, high-volume centers, primary retroperitoneal lymph node dissection, RPLND, is also increasingly utilized for select patients with small volume disease.
Especially when avoiding both radiation and chemotherapy is a high priority for the patient.
Exactly. But for the vast majority of community and academic practices, the daily reality is a head-to-head comparison between radiation and systemic chemotherapy.
And both modalities offer cure rates approaching 100% for this specific patient profile, right?
Yes, near 100%. So when efficacy is basically equivalent, the entire consult shifts. It moves away from a discussion of survival, and it becomes this really granular analysis of competing toxicities.
Yeah, and the toxicity profiles, these two modalities, I mean, they could not be more divergent.
It's apples and oranges. Let's break down the chemotherapy side of the ledger first.
Okay.
We are typically discussing 3 cycles of BEP, so that's bleomycin, etoposide, and cisplatin, or 4 cycles of EP, which is just etoposide and cisplatin.
Right. And the advantage there is profound because chemotherapy treats the entire systemic compartment.
Exactly. It eradicates the visible 2.4 centimeter node, but it simultaneously clears out any microscopic occult micrometastases that might be, harboring in the lungs or higher up in the mediastinum.
It's a full sweep, but the cost of that systemic sweep is incredibly steep.
It is brutal.
The acute toxicities are universally disruptive. We are talking about complete alopecia, severe nausea that requires really aggressive antiemetic regimens, and profound myelosuppression.
Yeah, the etoposide and cisplatin combination just hammers the bone marrow. It puts the patient at significant risk for neutropenic fever and really life-threatening opportunistic infections during their cycles.
But for a 38-year-old, it is really the late toxicities that require the most intense counseling, wouldn't you say?
Absolutely. The late effects of cisplatin are permanent. They are structurally damaging.
Because it's a heavy metal.
Exactly. Cisplatin works by forming cross-links with DNA, which disrupts mitosis, but its pharmacokinetics lead to this heavy metal accumulation in specific healthy tissues.
Like the kidneys.
Right. It accumulates in the proximal tubules of the kidneys, causing nephrotoxicity that manifests as a permanent decrease in the patient's glomerular filtration rate.
And we also see targeted damage to the nervous system, right?
We do, and this is interesting because cisplatin can't really cross the blood-brain barrier effectively, but the dorsal root ganglia, which house the cell bodies of our sensory neurons, they lack a robust blood-brain barrier.
They have fenestrated capillaries.
Yes, so the heavy metal just accumulates there, leading to a sensory peripheral neuropathy. And that can be totally irreversible, leaving these young guys with numbness, tingling, and pain in their hands and feet for literally decades.
That's awful.
It is, and it also selectively damages the cisternae vascularis and the outer hair cells of the cochlea.
Oh, the hearing loss.
Right, ototoxicity. Patients frequently develop high-frequency sensorineural hearing loss and chronic tinnitus.
And then, if the regimen includes bleomycin, if we're doing BEP, we introduce a really severe pulmonary risk.
Yes, bleomycin is terrifying in the wrong context.
Right.
It induces single and double-strand DNA breaks via oxidative stress, right? It generates free radicals.
Right. Now, most tissues in the body possess an enzyme called bleomycin hydrolase, which basically inactivates the drug.
Exactly, but the lungs are uniquely deficient in bleomycin hydrolase. They just cannot metabolize the drug efficiently,
So the free radical damage concentrates heavily in the pulmonary parenchyma.
which causes pneumonitis. And that can rapidly progress to irreversible, completely fatal pulmonary fibrosis. Especially, and this is a huge board pearl, especially if the patient is ever exposed to high concentrations of supplemental oxygen.
Like during a future surgery.
Exactly. Anesthesia has to know if a patient has had bleomycin.
Okay, so given that terrifying litany of systemic risks, radiation therapy often sounds highly appealing to the patient sitting in the room.
I mean, of course it does. It's localized. The treatment course is roughly 3 weeks of daily outpatient visits.
And the acute toxicities are, generally limited to mild fatigue, transient nausea, maybe some mild dyspepsia or loose stools.
Yeah, depending on how much bowel is caught in the low-dose bath.
Yeah.
But fundamentally, they keep their hair, they keep their hearing, and they maintain their baseline renal function.
So what's the catch?
The primary deterrent to radiation is the insidious threat of secondary malignancies.
Right.
We are taking a 38-year-old man who is almost certainly going to be cured of his seminoma. He's going to live into his 70s or 80s.
Right.
By applying ionizing radiation to his abdomen and pelvis, we are actively inducing double-strand DNA breaks in healthy mucosal and organ tissues.
And while most of those cells repair the damage perfectly or just undergo apoptosis, a tiny fraction will misrepair the DNA, initiating carcinogenesis.
Exactly. The linear no-threshold model dictates that any exposure carries a risk.
So over a latency period of, say, 10 to 20 years for solid tumors, this guy faces a statistically significant increase in the risk of developing GI malignancies
Like colon or stomach cancer, yeah.
and genitourinary malignancies, like bladder cancer,
Yeah.
or even a contralateral testicular tumor if the scatter dose wasn't strictly controlled during treatment.
And don't forget the cardiovascular risk. There is an accelerated risk of cardiovascular disease if the radiation field extends far enough superiorly to expose the heart or the major vasculature to premature atherosclerotic changes.
So really, you are laying out two very distinct survivorship realities for this guy. Option A involves managing potential hearing loss, neuropathy, and marginal renal decline from chemo.
Right.
And option B involves heightened cancer surveillance protocols for the rest of his life due to secondary malignancy risk from the radiation.
It is the absolute essence of shared decision-making. You have to lay it all out.
Okay, so let's throw a wrench into this. Let's introduce the pivot case.
Oh boy, let's do it.
We're going back to the original consult. Same 38-year-old guy, same isolated para-aortic node. The surgical pathology report on your desk clearly reads pure classic seminoma.
Okay.
But instead of normal post-orchiectomy markers, his AFP comes back at 65.
Uh-oh.
And a repeat draw 4 days later shows the AFP is 85. It is actively rising.
Okay, stop right there. The moment you see a rising AFP, that surgical pathology report in front of you becomes dangerously misleading. You must physically set it aside and entirely abandon the seminoma treatment algorithm.
Really? Just throw it out.
Just throw it out. A rising AFP is the ultimate histology override. You are now treating a non-seminomatous germ cell tumor, an NSGCT.
Okay, let's unpack the biological mechanics behind that override, because it trips people up. The pathologist sliced through a 4-centimeter testicular mass, analyzed multiple high-power fields, and saw nothing but uniform classic seminoma cells.
Right.
How can the blood work invalidate direct microscopic observation?
It comes down to the extreme heterogeneity of germ cell tumors. You have to remember, these tumors originate from totipotent germ cells. They are capable of differentiating into literally any tissue type.
So a single tumor mass can be a chaotic mosaic of pure seminoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma.
Exactly. And the pathologist, despite rigorous sectioning protocols, is only examining a microscopic fraction of the total tumor volume. It is entirely possible, and clinically it's quite common, for a tiny millimeter-sized focus of yolk sac tumor to completely evade the pathologist's blade.
And pure seminoma cells biologically lack the cellular machinery to produce alpha-fetoprotein. They simply cannot transcribe or translate it.
Right, they can't make it. AFP is a glycoprotein normally produced by the fetal yolk sac and fetal liver. In the context of testicular cancer, it is exclusively produced by yolk sac tumor elements or embryonal carcinoma elements.
Therefore, if the AFP is rising, it is incontrovertible biochemical proof that non-seminomatous elements are present somewhere in that patient's body, actively secreting the protein.
Regardless of what the sampled slides showed. And treating a patient with a rising AFP using a seminoma radiation protocol is catastrophic.
Because NSGCT elements are significantly more radioresistant than pure seminoma.
Vastly more radioresistant. The standard seminoma doses of 20 to 30 gray will completely fail to eradicate the yolk sac or embryonal components.
So you'd subject the patient to all the late toxicities of radiation,
while completely allowing the lethal, aggressive non-seminoma clones to proliferate and metastasize widely. It's a worst of both worlds.
Okay, what about beta-HCG? Does a rising beta-HCG trigger the exact same histological override? Like, if his AFP was strictly normal, but his beta-HCG was persistently climbing, do we still throw out the seminoma diagnosis?
We do not. Beta-HCG represents a really nuanced exception here.
How so?
Well, dramatically elevated beta-HCG levels often suggest the presence of choriocarcinoma, which is a highly aggressive non-seminoma element. But mild to moderate elevations of beta-HCG can actually be produced by pure seminoma.
Oh, right, because of the syncytiotrophoblastic giant cells.
Exactly. About 15 to 20% of pure classic seminomas contain those syncytiotrophoblastic giant cells. And those specific cells retain the ability to secrete beta-HCG without altering the fundamental biological behavior or the radiosensitivity of the seminoma itself.
Okay, so an isolated, moderate beta-HCG elevation does not automatically force you into the NSGCT algorithm, provided the AFP remains strictly normal.
Correct, but we have to be meticulous about the trajectory of the AFP.
Right, the vector.
Yeah, if the AFT is 12 and the lab's upper limit of normal is 10, we don't panic and initiate immediate NSGCT induction chemotherapy. Mild, stable elevations can be attributed to hepatic etiologies.
Like heavy alcohol consumption, or viral hepatitis, or fatty liver disease. That can cause mild hepatocellular irritation, leading to a little bump in AFP.
Exactly. The critical diagnostic factor is the vector. We need a clearly rising trend over multiple serial draws to confirm active tumor suppression.
And if that rising vector is confirmed, and we establish the stage IIA NSGCT diagnosis, radiation is completely off the table.
Gone. The standard framework for marker-negative stage IIA NSGCT revolves around primary RPL-ND or systemic chemotherapy.
And for stage IIB, NSGCT.
The pendulum swings heavily towards systemic chemotherapy due to the higher volume of disease, with surgery reserved for highly selected, specialized scenarios.
Okay, let's reset the board and return to our baseline reality.
Bye-bye pivot case.
Right, the pivot case is gone. Our 38-year-old has his 2.4 centimeter node, true pure classic seminoma, and strictly normal markers.
Okay, back to the gray zone.
We have thoroughly counseled him on the toxicity trade-offs. He weighs the options and decides he really wants to avoid the systemic risks of blue mucinous cisplatin. He chooses radiation.
Okay, he wants RT.
The examiner now asks you to design the treatment field. But before we even turn on the simulator, we have to ensure we aren't walking into a dosimetric trap.
Oh, this is vital. There are specific anatomical and clinical scenarios where definitive abdominal radiation is so fraught with hazard that we must actively steer the patient back toward chemotherapy.
Right, and we use the mnemonic HIPP to rapidly recall these contraindications.
HIPP. Let's break down the H. It stands for horseshoe kidney.
Right, which is a congenital anomaly where the lower poles of the bilateral kidneys literally fuse across the midline during fetal development.
Exactly. So instead of sitting high up in the retroperitoneum, safely tucked under the ribs, this big fused renal mass is trapped lower in the abdomen. It's typically draped directly over the lower abdominal aorta and the aortic bifurcation.
Which is exactly where we need to treat. If we attempt to treat the standard periortic and iliac nodal chains, that massive fused kidney is sitting right in the dead center of our target volume.
Yep. We would be delivering therapeutic radiation doses to an enormous volume of functional nephrons. It basically becomes mathematically impossible to meet our normal tissue constraints.
You're practically guaranteeing severe radiation nephropathy and eventual renal failure.
Exactly. So horseshoe kidney means we pivot to chemotherapy.
The I in HIPP stands for inflammatory bowel disease, specifically active Crohn's disease or ulcerative colitis.
Right. The mucosal lining of the gastrointestinal tract is characterized by very rapid cellular turnover. That makes it inherently sensitive to ionizing radiation. Now, in a healthy patient, the bowel can repair the mucosal damage caused by fractionated radiation just fine.
But in a patient with active IBD, that mucosa is already in a state of chronic aggressive inflammation and ulceration.
Right. Their baseline repair mechanisms are completely compromised.
So subjecting that fragile diseased bowel to pelvic and abdominal radiation risks catastrophic, acute, and late GI toxicities.
We are talking about intractable diarrhea, transmural bowel necrosis, fistula formation, severe strictures requiring surgical resection, massive hemorrhage. It's bad. Active IBD is an absolute contraindication to this field.
Okay, the first P represents a pelvic kidney.
And the logic here basically mirrors the horseshoe kidney scenario. If a patient has an ectopic kidney that failed to ascend during embryogenesis and remains lodged in the ipsilateral pelvis, it will be sitting directly inside the flaring portion of our modified dogleg field.
It would just obliterate its function.
Exactly.
And the final P is prior overlapping abdominal or pelvic radiation therapy.
Right. Tissues like the spinal cord and the bowel have strict lifetime cumulative dose limits. If a patient previously received significant radiation to this region, say for a different pediatric or adult malignancy, we simply do not have the dosimetric bandwidth to safely re-irradiate the area to definitive doses.
Because exceeding those lifetime constraints courts total disaster, like transverse myelitis or bowel necrosis.
Exactly. So HIPP, horseshoe kidney, IBD, pelvic kidney, prior RT. You have to check for all four.
But our patient's anatomy is pristine, so we proceed to simulation. He is positioned supine for a CT-based planning simulation. Now, what is the immediate critical requirement before we do anything else?
The application of a clamshell squirtal shield. You must mention this to the examiner.
Always.
Unless the patient has a solitary testis and has already undergone a bilateral orchiectomy, you have to say clamshell shield.
We need to dive deep into the physics of why that shield is mandatory. Because think about it, the primary tumor is gone. The target volume is in the high abdomen, way up near the renal hilum. Why are we shielding the contralateral healthy testicle that is sitting far outside the primary radiation beam?
Because even though the primary beam is perfectly collimated and aimed far superiorly, radiation is not perfectly contained. We are dealing with two physical phenomena here: head leakage and internal scatter.
All right, head leakage refers to high-energy photons that actually manage to escape through the thick tungsten shielding of the linear accelerator's treatment head.
Yep. But more importantly, we deal with internal Compton scattering.
Ah, Compton scatter.
Right. When the primary high-energy photon beam interacts with the atoms in the patient's abdominal tissues, it causes electrons to eject and secondary photons to literally scatter in all directions.
Including inferiorly straight down into the pelvis and the scrotum.
Exactly. And the healthy testicle is exquisitely, incredibly radiosensitive. It houses two primary cell populations: the Leydig cells, which produce testosterone, and the germinal epithelium, which produces sperm.
And while those Leydig cells are somewhat robust, the germinal epithelium can be temporarily or even permanently sterilized by shockingly low doses of radiation.
We are talking about cumulative scatter doses as low as 1 to 2 gray, causing profound oligospermia or azoospermia.
Just from scatter.
It's from scatter. So the clamshell shield is this physical, heavy lead cup that securely encases the scrotum. Now, to be clear, it cannot protect against the internal scatter originating from within the patient's own body.
Right, the photons coming from inside.
Exactly. But it highly attenuates the external scatter from the collimators and the head leakage. By utilizing the shield, we can generally keep the cumulative dose to the contralateral testicle well below the threshold for permanent damage, preserving his remaining fertility and endocrine function.
Okay, so with the patient simulated and shielded, we move to the treatment planning system. In modern radiation oncology, I feel like we reflexively reach for IMRT intensity modulated radiation therapy, or VMAT, to achieve highly conformal dose distributions. We want to wrap that high dose volume tightly around the target and avoid the surrounding organs.
We do.
But for stage 2 seminoma, pulling out the advanced IMRT tools is an active mistake, right? We actually revert to older technology.
Yes. You must confidently state that for standard photon treatment, a 3D conformal anterior to posterior to anterior plan, the classic APPA fields, remains the gold standard. It is the preferred answer over IMRT.
And the examiner will definitely push you on this. They will ask why you are ignoring modern technology that clearly spares high doses to the bowel.
And your defense centers entirely on the concept of integral dose and the low-dose bath. IMRT achieves its beautiful, tight, high-dose conformality by utilizing multiple beam angles or continuous arcs. It fires radiation from numerous trajectories through the patient's body.
Right.
But the unavoidable physical trade-off is that to achieve that high-dose tightness, IMRT spreads a very low dose of radiation over a vastly larger volume of normal, healthy tissue laterally.
Right, the low-dose bath. And in an older patient with a palliative malignancy, that low-dose bath is basically irrelevant.
Exactly. But in a 38-year-old with a highly curable disease and a 40-year life expectancy, increasing the integral dose, the total energy absorbed by the body, theoretically increases the risk of inducing a secondary malignancy.
So a simple APPA setup restricts the radiation to a strictly defined rectangular column passing straight through the body front to back.
Yes. The lateral tissues, the flanks, the lateral bowel, the liver edges, they receive effectively zero dose. In this disease, we prioritize minimizing the exposed volume over minimizing the high-dose conformality.
Okay, we have our APPA modality selected. Now we need to define the actual borders of the classic modified dogleg field. The goal is to comprehensively cover the para-aortic nodes and the proximal ipsilateral iliac nodes.
Right.
If we logic this out, we know the primary landing zone is near the renal hilum. We need our superior border to be high enough to capture the nodal tissues surrounding the renal vessels as they join the IVC and aorta.
So the classic bony landmark for the superior border is placed right around the T11-T12 junction, or the superior end plate of the T12 vertebral body.
And then moving inferiorly, we follow the lymphatic chain down the aorta, past the bifurcation, and along the common and external iliac vessels on the ipsilateral side.
But we have to stop before we needlessly irradiate the true pelvis and the bladder. So the standard inferior border is set at the top of the acetabulum on the ipsilateral side.
And the shape of the field is iconic. The superior segment is a relatively narrow central strip that covers the midline aorta and IVC. As you track inferiorly past the aortic bifurcation, the field flares out laterally, exclusively on the ipsilateral side, so the left side in our case, to capture those iliac nodes.
And that straight vertical strip combined with the unilateral inferior flare creates a shape that literally mirrors the hind leg of a dog, thus the dog-leg field.
Exactly. And even if you are utilizing modern vessel-based contouring, you are creating a clinical target volume by adding an asymmetric margin around the aorta and IVC superiorly and the ipsilateral common and external iliac vessels inferiorly.
Right, followed by a planning target volume expansion to account for setup error and respiratory motion. But the fundamental geometric footprint remains the dogleg.
Let's discuss the dosimetry. We have our field. How are we actually prescribing the dose? For stage IAE disease, we utilize a biphasic approach with no planned breaks.
Right. Phase 1 involves treating the entire large modified dogleg field to a dose of 20 gray, delivered in 10 daily fractions of 2 gray each.
And once we hit 20 grays, we execute a cone down. We drastically shrink the radiation field. We no longer treat the entire dogleg. We target only the gross disease, that 2.4 centimeter node we found, along with a tight margin.
Yep. We deliver a localized boost of an additional 10 gray to that smaller volume. This brings the total dose for stage IIA seminoma to exactly 30 gray.
Now, if our patient has stage IB disease, say a 3.5 centimeter node, we rely on the exact same initial field. Phase 1 remains 20 gray and 10 fractions to the large modified dogleg.
The difference lies entirely in the magnitude of the cone-down boost.
Right.
We boost the gross disease to a higher total dose of 6 gray to overcome the increased tumor burden.
And while delivering these doses, we absolutely must respect strict normal tissue constraints, particularly for the kidneys, because they are so intimately involved in the periaortic region.
Yeah, the pathophysiology of radiation nephropathy involves damage to the delicate capillary network of the glomeruli and the tubular epithelium. It leads to this gradual sclerosis, proteinuria, and declining filtration capacity over months to years.
So to prevent this, the classic board constraint mandates that no more than 50% of each individual kidney can receive a dose of 8 gray or higher. We're ensuring that at least half of each kidney's functional subunits remain entirely uncompromised.
But the clinical scenario becomes highly complex if the patient only possesses a solitary functioning kidney.
Oh, yeah.
In that case, the constraint becomes dramatically tighter. No more than 15% of that solitary kidney can receive 20 grays or more.
15%.
Yes. If your treatment plan cannot meet that 15% threshold, you are risking catastrophic dialysis-dependent renal failure. In that situation, you must return to the patient and strongly advocate for a pivot to systemic chemotherapy.
Okay, so these precise doses, the 20 gray, the 30 gray, and the evolution of the field designs, they didn't just materialize from thin air. They are the product of decades of rigorous, iterative clinical trials, predominantly championed by the Medical Research Council, the MRC, in the United Kingdom.
Oh, the MRC trials. We have to know these.
We need to dissect the 3 landmark trials that built the modern standard of care: MRC TE10, TE18, and TE19.
Let's start with MRC TE10. This trial fundamentally altered the management of stage I seminoma. In the early eras of radiation oncology, the dogma dictated that even for stage I disease, where no visible spread was present, the entire modified dogleg field was required prophylactically to sterilize microscopic disease in both the para-aortic and pelvic chains.
Which means the toxicity, particularly the acute nausea and myelosuppression, was significant.
It was. TE10 dared to challenge that dogma. It randomized stage I patients to either the massive classic dogleg field or a much smaller, simpler para-aortic strip that entirely omitted the pelvic flare.
And radiation oncologists at the time were incredibly anxious about dropping that pelvic coverage, fearing a wave of catastrophic pelvic recurrences.
Exactly, but the results were practice-changing. The smaller para-aortic strip resulted in significantly less acute toxicity. Patients tolerated the treatment vastly better.
There was, however, a biological reality to face. By omitting the pelvic field, the rate of isolated pelvic relapses did increase slightly, right?
Yes, jumping from roughly 1 or 2% in the dogleg arm to about 4% in the para-aortic arm.
And that 4% recurrence rate sounds alarming until you examine the salvage data. Seminoma is so exquisitely sensitive to subsequent treatments that those isolated pelvic relapses were almost universally cured with salvage chemotherapy or further targeted radiation.
Exactly. Because the salvage rate was near perfect, the overall survival between the large field and the small field was statistically identical. TE10 successfully proved that we could de-intensify the spatial volume of the field for stage I, sparing toxicity without sacrificing survival.
Okay, moving to MRCTE18. This one tackled the other variable, dose. The historical standard for stage eye disease was 30 gray. TE18 randomized stage eye patients to either the traditional 30 gray or a reduced dose of 20 gray, delivered in 10 fractions.
And the hypothesis there was that seminoma's extreme radiosensitivity meant we were significantly overtreating microscopic disease.
And TE18 confirmed this, right?
It did. The recurrence rates were virtually identical between the two arms, but the patients receiving 20 gray experienced substantially less acute fatigue, lethargy, and GI distress. TE18 permanently established 20 gray in 10 fractions as the modern, definitive radiation dose for stage eye seminoma.
Finally, MRCTE19 introduced systemic deintensification. It established that a single cycle of carboplatin chemotherapy dosed using the AUC formula based on glomerular filtration rate was a safe and highly effective alternative to radiation therapy for stage eye seminoma.
Right, it offered a systemic option that completely avoided the long-term secondary malignancy risks associated with abdominal radiation.
Now, it is vital to note that in contemporary practice, active, rigorous surveillance is the preferred management strategy over both radiation and single-agent carboplatin for the vast majority of stage A patients. But TE19 cemented carboplatin's position as a viable alternative when intervention is necessary.
The overarching theme of these MRC trials is a relentless push toward de-intensification, smaller fields, lower doses, less toxic systemic options. And that philosophy is really bleeding into stage 2 research today.
Yeah, there are active protocols investigating hybrid de-intensification strategies for stage 2 disease, like utilizing a single dose of systemic carboplatin to clear micrometastatic disease, followed by highly focal involved node radiation that targets only the enlarged node, completely abandoning the massive dogleg field.
Those trials are scientifically fascinating, and they probably represent the future of our field. However, a major warning must be issued here.
Yes, please.
If you are sitting in your oral boards or advising a community practitioner and you are asked for the classic management of stage IIA seminoma, you cannot offer an experimental phase 2 de-intensification protocol as your primary answer. You just can't.
Right. You must provide the established standard of care, the 30 gray modified dogleg, or multi-agent cisplatin-based chemotherapy. You have to demonstrate mastery of the gold standard before you start theorizing about the future.
That distinction is crucial.
Okay, let's put all of this clinical reasoning to the test. We are entering the rapid-fire scenario section. We are going to bypass the multiple-choice format and simulate the actual friction of an oral board exam. I will play the examiner trying to bait you into traps.
Yeah.
You play the resident defending your logic.
All right, I'm ready. Let's do it.
Here's scenario 1. I slide a CT scan across the table. The patient is a 32-year-old with a confirmed pure seminoma on orchiectomy. Markers are strictly normal. The CT clearly demonstrates a solitary 1.5 centimeter left para-aortic node. I lean back, cross my arms, and say, "Doctor, we've discussed shared decision-making," and the patient adamantly refuses chemotherapy. He wants radiation. Since the node is so small, and we know from MRCTE10 that shrinking the field is safe, I want to treat him with a simple 20 gray para-aortic strip. Do you agree with my plan?
I respectfully push back on that plan. While the node is small, it is radiographically enlarged at 1.5 centimeters. Provided we have waited the appropriate 6 to 8 weeks to confirm it isn't reactive, this patient is classified as stage IIA, not stage 1. The MRCTE10 data, which validated the 20 gray para-aortic strip, strictly applied to stage I patients with no evidence of macroscopic disease. For stage IIA, the presence of gross retroperitoneal disease alters the risk profile for adjacent lymphatic chains. The standard of care mandates the larger modified dogleg field to cover the iliac nodes and a higher total dose of 30 gray to adequately sterilize the macroscopic burden. Treating him with a 20 gray strip risks a massive underdosing of the gross tumor and a high probability of marginal miss in the pelvis.
Excellent defense. You identified the subtle trap of applying stage I data to a stage 2 clinical scenario. Let's move to scenario 2. A patient presents with marker-negative stage IIB seminoma. The imaging shows a 2.8 centimeter retroperitoneal mass. I look at you and say the node is pushing 3 centimeters, it's bulky. Radiation is clearly insufficient for this volume of disease. I'm scheduling him for induction EP chemotherapy tomorrow. Are you comfortable signing off on that order?
I would pause the induction order. While EP or BEP chemotherapy is an excellent Category 1 option for stage IIB disease, it is absolutely false to state that radiation is insufficient. For low-volume stage IIB seminoma, and a 2.8 centimeter node sits at the very lower end of the IAB spectrum radiation to 36 gray, utilizing a modified dogleg field is an equally valid standard of care option. We cannot mandate chemotherapy without a comprehensive discussion with the patient regarding the divergent toxicity profiles. If this patient has baseline hearing loss, pre-existing neuropathy, or compromised renal function, radiation might be the vastly superior choice. Both options must be presented.
Perfect. You avoided the rigid dogma trap and prioritized shared decision-making based on toxicities. Final scenario. A 29-year-old man has a pathology report confirming pure classic seminoma. His post-orchiectomy AFP is 95 and rapidly climbing. His CT shows a 1.6 centimeter para-aortic node. I say the node is small, it's only 1.6 centimeters. The pathology is pure seminoma. We're going to treat him with a 30-gray modified dog-leg field. Detail your simulation setup.
I will not simulate this patient. The rapidly rising AFP of 95 fundamentally invalidates the seminoma pathology report. Pure seminoma cells do not produce alpha-fetoprotein. The rising marker is biochemical proof that non-seminomatous elements, such as yolk sac tumor, are present and actively proliferating.
Right.
NSGCT elements are inherently radioresistant. Delivering a 30-gray modified dogleg field would be a catastrophic clinical error. It would fail to control the disease and allow aggressive metastasis while inflicting radiation toxicity. This patient requires immediate transition to the NSGCT algorithm, which mandates multi-agent cisplatin-based systemic chemotherapy based on IGCCG risk stratification.
You nailed every single trap. That is the exact level of confident, biologically grounded reasoning required.
It's all about staying alert.
Absolutely. As we synthesize this discussion, the overarching lesson is that managing stage II testicular cancer demands relentless vigilance. You must verify the marker status, specifically the trajectory of the AFP. You must confirm that borderline adenopathy is truly metastatic by utilizing the 6 to 8 week waiting game. You must rigorously measure the nodes to differentiate IIA from IIB because that dictates your radiation boost dose.
And crucially, you must deeply understand the profound, lifelong toxicity trade-offs between radiation and chemotherapy to counsel these young men effectively.
If the disease is a confirmed marker-negative stage IIA seminoma, both modalities are weapons at your disposal. If the AFP is rising, you immediately pivot to the non-seminoma paradigm.
And if you are called upon to deliver radiation for pure seminoma, you must be able to expertly design, defend, and execute the classic modified dogleg field, respecting the strict constraints of the surrounding anatomy.
As we step out of the clinic today, I want to leave you with a provocative thought. We dissected how the MRC TE10 trial courageously shrank the radiation field for stage 1, fundamentally altering decades of practice. Today, we are witnessing an explosion of modern de-intensification trials attempting to shrink the footprint even further for stage 2 disease. As the survivorship data for these young men matures over the next 20 years, granting us a hyper-clear picture of the long-term, decades-late toxicities of definitive radiation versus systemic platinum-based chemotherapy, how will the scales tip? Will the biological precision of novel systemic agents or advanced imaging techniques render these massive regional radiation fields entirely obsolete? Is it possible that the modified dogleg field, a cornerstone of our discipline, will be completely erased from the textbooks of the future? It is the cutting edge of our evolving field. Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.